So much for your invitation to speak to this House on women's health with International Women's Day this coming Saturday, and I am struck. Thank you for the invitation from the ladies of this House for the invitation, and it is wonderful, and I'd like to congratulate and thank Senator McDowell for coming into the room. I did notice, and it was well commented on by the ladies in here, that there was quite a lot of men in the previous debate, and that there was something of a not quite a stampede to the door, but my goodness, quite a rush to the door. And it is wonderful to speak yet again with women about women's health and women's issues in International Women's Week, Women's Health Week. So Senator McDowell, you are gloried among women. Thank you for being here. It's sort of pointless to have to make these remarks continually, but there we are. As a female Minister for Health and a female member of the Oireachtas, I am more than ever struck about the total unnecessary, why these weeks should be necessary. I really do have a sort of a cranky difficulty with continuous focus on women being different or having to be different. Women for election, women in finance, and I was in the Department of Finance, women's health, as though women aren't half the population. I'm the only female representative for the Dún Laoghaire constituency, not just in this Dáil, but in the last Dáil. For some reason, women have to go out of their way to highlight the different issues that have led to so many different inequalities, and health is one of those. So perhaps let's just focus on a health service for everybody, as recognising the basic dignity, human rights and respect that every person, male or female, deserves in the health system and right across the rest of society. I would like to highlight, though, that there are some issues that do impact women more than men. Obviously, one of those is maternity, of course, naturally. And I would like to highlight in particular, and recognising that this is Women's Health Week, that the maternity system and the impact on women is very considerable. And the reason I want to mention it is because I want to recognise the women who have had difficult experiences in Portjunkilla and Ballinasloe, where I've travelled twice in the last number of weeks to meet and sit with those women and spend time with those women whose babies' births, and in some cases whose babies' deaths, are the subject of review. And what is clear to me, and the reason I highlight it, is that time and time again, even in maternity, that there seems to be a systemic difficulty in actually listening to the voices of women, including heavily pregnant women in maternity units. And that's not unique to this situation, but across the situation, across maternity hospitals and across maternity units, where again, no matter what report I read into the lack of care or incidences of adverse incidences, time and time again, including the most recent report on the working group on medical negligence costs, women highlighting that they didn't feel that they were listened to, and how often that impacts on their care. And that's not just in the case of maternity questions, but this morning I opened a women's health initiative in cardiovascular care, where it's not that women aren't listened to, but because their symptoms present more subtly and in a more nuanced way, it's often not recognised or understood as a cardiovascular issue. Now, the Women's Health Fund in my department have put very considerable funding to try to address 3 specific projects between Vincent St Michael's in Dún Laoghaire and UCD to try to shine a particular light on this, not just the operation of bias in some of the diagnostics, but also the tracking where there's particular risk factors in gestational diabetes and other markers in the maternity system that may lead to cardiovascular difficulty. So there's so much to do, but recognising that women may present differently and that that's not a question of bias, that's simply different symptomatic presentation, and that women have to be listened to and understood and respected in the most basic way. And it seems ridiculous to have to say this out loud, but nevertheless, women's experiences and symptoms can be different to men's, and so these wrong diagnoses, inadequate treatments lead to poorer results, and that's a systemic issue that we have to recognise. I'd like to welcome Senator Clonan and other Senator. Sorry, I'm so sorry. It's delighted to see you. Thank you for coming to Women's Health Week. But inequalities in health mirror inequalities that women face in other areas of life, and I don't just want to focus on inequalities in women's health in Ireland. Next week I'm at the United Nations on the Commission on Status of Women, and I do want to recognise the very considerably greater difficulties that many women around the world are facing in terms of health inequalities more broadly around the world. And I think it's always important to recognise our own, reasonably privileged position, favourable position vis-a-vis many other women, and of course some of the intersectional issues that women in Ireland face in terms of their health. But a week like this, as unnecessary as it should be, nevertheless enables all of us to shine a particular light on issues that were previously shrouded in some silence. In past, we only heard something like menopause being mentioned in whispers. Thankfully, the silence around that periods, endometriosis has begun to lift, and that public conversation being louder has driven, thankfully, service delivery at a better level, though there is much to do. That work has been enabled through the Women's Health Task Force, and I do want to thank each member of the task force for their work. Their work, driven by the demands of women, has provided the foundation for the Women's Health Action Plans. And there has been good progress made, and may I say, I want to pay tribute to Stephen Donnelly, my predecessor, who drove much of that work with the Women's Health Task Force. But it's a starting point. There is an awful lot to do, and I'm excited to work with all of you to find the particular areas where we can do considerably better. So I'm delighted to work with all of you on all of that. Nevertheless, let's recognise some progress. The government has invested an additional €180 million since 2020 in women's health. And that dedicated initiative has resulted in the beginning of new initiatives across the country, often first of their kind. So, for example, there's the free contraception programme for women aged 17 to 35. There's much better investment in screening services and a commitment in the programme for government to go further with that based on clinical advice, where, what the clinical advice, not politicians' thoughts, but clinical advice. We've expanded termination of pregnancy services and established, and I think we're at 18 out of 19 maternity units now, and soon to be 19. I'll have an update for the House in a number of weeks in relation to that. We've established a growing network of C and treat gynaecology clinics, which are working quite well. We've developed public services for fertility, and for the first time a limited funding for IVF for people whose fertility issues cannot be managed at primary or secondary care level. And again, recognising that those are many good starts and that there may be more to do, and ways of examining how we might get better value or better outcomes, or spread that particular fund in a more effective way. This year we'll see further work on the establishment of the Assisted Human Reproduction Authority, with the enactment of the Amendment Bill and the establishment of the authority. Obviously, two key elements that will enable then expanded eligibility for AHR, and we're getting closer to the opening of the first public AHR centre in Cork. We have established hubs for the treatment of endometriosis. Now, I know most endometriosis cases can be managed perfectly well with a GP or primary care setting, but there is a need for complex intervention and for complex services. We now have hubs that have treated about 1,100 of the more complex cases, but I think there's quite a bit more to do in that, and to recognise the impact that has on people's lives. Similarly, we've started to meet women's long overdue right to treatment for the management of menopause. And while, again, much of that can be done at primary care level, and we've been working with GPs to improve awareness and training, we've also established 6 specialist clinics for the treatment of more complex cases. And I appreciate that these clinics run at limited capacity, but they're an example of a start and where we would like to go further with them. And as we continue to implement the National Maternity Strategy, we'll be opening 8 new postnatal hubs to improve the care provided to new mothers and their babies. I don't know if any of you have spoken to new mothers who have had the opportunity to experience these postnatal hubs, but the feedback that I'm getting, and I'd be interested in your feedback, is that they have been quite positive and constructive in the first instance, so I'd be interested in your feedback on that. They have proven good support to women with breastfeeding, physiotherapy and other emotional and physical supports for up to 14 days post-birth, which is a very, very delicate time. We have 4 additional C and treat gynaecological clinics being put in place to complete the national network of 21 clinics for the fast and efficient management of gynaecological conditions. And those clinics have had a big impact on waiting times for those procedures. And we're also working to improve breastfeeding rates, recruiting additional lactation consultants to support women on their breastfeeding journey, and developing a new national breastfeeding strategy. And all of that works while we continue to progress the tender process for the new National Maternity Hospital. We're working hard to get to a place where everyone has access to quality, tailored care that provides treatment appropriate to our physiology and research appropriate to our physiology. Through the Women's Health Action Plan, my department is also investing in such research that will expand the evidence base for women's health and lead to better healthcare. And I mentioned this morning about the project in Dún Laoghaire with the cardiovascular project, which is one such example of that. Some voices, though, still, with this focus on Women's Health Action Plan, some voices still don't get heard quite loudly enough. And there's some groups that are still left behind. And we're trying to produce programmes that will really target women who might, for different reasons, be harder to reach. So, for example, we've introduced a pilot programme to support Ireland's effort to eliminate cervical cancer by improving the HPV vaccination rates, not just with girls but with boys, but also in every community, and in some healthcare underserved communities, which may include traveller, Roma and certain migrant groups living in Ireland. We've also supported a project to raise awareness among women and girls on the signs and symptoms of common types of cancer in different communities across Ireland. And we continue to build on initiatives such as the provision of free period products, providing free tampons and pads to women in every community, placing them in the bathrooms of public buildings. It might seem like a small step, but it's a recognition that that it's a natural part of life, but also that some women may be disadvantaged because of financially disadvantaged. So we are working seriously to get, I would very much like to see a period where we don't have to have these weeks or these specific task forces, and where women are just part of the national conversation in a completely normal way. I recognise that that is not yet so. Nevertheless, on the other hand, women are living longer than men by 84 years to about 80 years. Nevertheless, our health outcomes in cardiovascular care, osteoporosis, and certain cancers are more prevalent in women, like lung cancer. You would think that it would operate, equally between men and women, but in fact, women are getting it much more often. So there are certain outcomes because of women's sex that are more difficult, and it's important that while we are shining a light on women's health action plans generally and the work to support women in their healthcare across the board, that we are making sure that we have appropriate responses for the physiological differences of women, that we are having serious research directed at improved women's health outcomes, and that we are getting to the point where women's health is treated as naturally as all health, and that there's no real differentiation. And I would very much welcome your contribution to that. Thank you.